Stevens-Johnson syndrome. Our case was an 18-year-old male who presented to us in 2017 and was diagnosed to have chronic SJS sequelae. He underwent left eye both lids MMG and right eye upper lid MMG. He was lost to follow-up and he presented to us 5 years later with a stable ocular surface in left eye and a keratinized lower lid margin, inferior bulbar surface and inferior cornea. A right eye lower lid and bulbar surface MMG was planned. During surgery, stay sutures were placed to both lids using 4-0 silk. Using 15 size blade, incision was given along the grey line and 5 mm posterior to the lid margin. Using limbs forceps and Vanna scissors, a dissection is done carefully along the lid margin, removing only the skin and the keratinized part of the posterior lid margin. Care is taken to not excise excess tarsal tissue. The keratinized conjunctiva over the tarsal surface is also excised. Now the bulbar surface keratinized conjunctiva is excised, taking care to not remove excess of Tenon's tissue. The dissection is started at the limbus and then proceeded towards the fornix. The corneal keratin is removed using a 15 size blade. The surface is smoothened and finally a keratin-free surface is achieved. The bare area is measured using a sterile scale and the same area is harvested from the lower lid labial mucosa. The area to be harvested is marked with the marker pen. And incision is made using a 15 size blade. Submucosal dissection is done along the lamina propria plane, making sure that excess fat tissue, salivary gland lobules and muscle tissue are not included in the graft that is harvested. The lip wound is sutured with 7-0 vicryl in a continuous interlocking fashion. The graft is placed over glabella and excess fat tissue is trimmed using curved part of Westcott scissors. The graft is divided into two equal halves, one half for the lower lid margin and the other half for the bulbar surface. The graft is sutured to the lower lid margin using 7-0 vicryl in a continuous interlocking fashion. The graft is thoroughly hydrated during suturing to avoid shrinkage of the graft. Posterior margin of the graft is attached using fibrin glue. Ironing of the graft is done using iris depositor. The second half of the graft is placed on the bare area of the bulbar surface and fibrin glue is used to adhere the graft to the bulbar surface. The caveat here is to keep a minimum gap of 1 mm from the limbus to avoid migration of the graft onto the cornea later on. To keep the graft in place, in addition to fibrin glue, stay sutures are placed using 7/0 vicryl at all 4 ends and 2 sutures in the middle of the graft. A total of 6 sutures are placed to keep the graft in place. An amniotic membrane overlay is performed for the corneal epithelial defect. 2 weeks later, we can notice that the keratin has not recurred and the graft is well taken up over the bulbar surface and lower lid margin. At 1 month post-operative visit, the vision had improved from hand movements in the preoperative period to 20 to 50 1 month after surgery. There is also regression of corneal vascularization. The graft is well vascularized and well integrated on the bulbar surface and lid margin at 1 month post-op. Thank you for your patient listening.
Very nice video, Shilpa, and nicely operated. So I just wanted to ask you, when you place the mucous membrane graft on the eyelid, you are placing it over the meibomian gland orifices. I understand that majority of them have already by this time have undergone cicatrization.
Atrophied.
But how commonly do you see chalazion in these patients post-op? Because the meibomian gland orifices are now obstructed by your MMG graft.
Yes, so not much experience on long-term follow-up, but what we were taught is to you milk the meibomian glands before doing meibomian mucous membrane graft. So how often? Yes, we do see chalazion in patients. I have seen 2 of my MMG patients having chalazion later on.
Yeah, and they're very refractory and difficult to treat, those chalazions.
Yeah.
Thank you.
Nice video. Thank you. We'll
Thank you.
move
Thank
on
you so
to
much.
The next presenter. And the next presenter is Dr. Soumya Vigisna. Is she here? No? Okay. So next video is to be presented by Dr. Sathya Ravila. She'll come later? Okay, sir. Okay, so coming on to the next presenter, Dr. Sneha Pandurangan. Okay, you're here. So your video is, the topic is get associated with the orthoptic evaluation of dissociated vertical deviation.
Yes.
Okay, you can start. Thank you.
Dissociated vertical deviation is the tendency of the non-fixating eye to elevate, abduct and extort spontaneously, in which case it is called as manifest DVD, or when binocularity is suspended, in which case it is called latent DVD. It is usually a dissociated strabismus complex, of which dissociated vertical deviation is the most prominent. This child exhibits a right manifest dissociated vertical deviation when the left eye is fixing. When the left eye is occluded with the help of the Spielman occluder, the right eye shows a quick downward and inward refixation movement, while the left eye under cover shows a slow upward-outward movement. The same is exhibited when the right eye is occluded. This child has a bilateral dissociated vertical deviation. Dissociated vertical deviation is graded quantitatively into small, moderate, and large based on the measured deviation. Quantification of DVD has a high inter and intra-observer variability due to associated latent nystagmus, unstable endpoint, and redress. The prism undercover test is the gold standard and it estimates both manifest as well as latent DVD. Even with prism undercover test, only 33% of cases exhibit a stable endpoint. This patient exhibits a right manifest DVD with an alternating exotropia. When the left eye is covered with a translucent Spielman occluder, there is a downward-inward refixation movement of the right eye. While on reversing the cover, the left eye shows only a horizontal refixation and the right eye under cover shows a slow upward-outward drifting. When the horizontal deviation is neutralized with a 30 PD basin prism, the dissociated vertical deviation of right eye is more prominent. Moving on to prism undercover test. To place in front of the hyperdeviating eye, an 8 PD base down prism is chosen arbitrarily based on the corneal reflex. Both the prism and occluder are brought in front of the hyperdeviating eye simultaneously. The cover is left in place for a minimum of 5 seconds and shifted to the fixating left eye. The right eye is looked for any refixation movement. With 8 PD, there is a persistent downward refixation movement. The prism undercover test is repeated with 12 PD base down prism and the downward refixation movement is neutralized. It is important to note that the cover is left in place while the prism is being changed. This process is to be repeated with right eye fixing in order to measure the DVD of left eye. DVD is said to be symmetrical when the measured hyperdeviation is same in both the eyes. When the difference between the two eyes is more than 10 prism diopters, then it is known as asymmetrical DVD. Dissociated vertical deviation is usually bilateral and it is usually asymmetrical. The prism undercover test for committance. Dissociated vertical deviation is said to be committant when the difference in measured deviation in abduction, primary and adduction is within 7 PD. Why should one know about the committance of dissociated vertical deviation? In general, dissociated vertical deviation is larger in abduction than in adduction and larger in down gaze than in up gaze. When associated with an oblique muscle overaction, an incommittance is to be expected. Committance of DVD is to be measured at 30 degrees of adduction and abduction, and this is achieved with the help of a goniometer. With the left face turned to 30 degree and right eye in abduction, the prism undercover test is repeated. On neutralizing the horizontal deviation, right eye DVD in abduction is noted. To To perform the prism undercover test, the occluder is left in place and a 6 PD based on prism is used, with which the dissociated vertical deviation of right eye is neutralized. With 30-degree right face turn and the right eye in adduction, the prism undercover test is again repeated. Dissociated vertical deviation is more prominent and the deviation is neutralized with a 12 prism diopter of base down prism. Remember to repeat the prism undercover test with each eye fixing to measure the DVD of each eye separately. The occluder is to be held in place for a minimum of 5 to 10 seconds to allow maximum dissociation. DVD should be measured in 30-degree adduction and abduction in order to rule out concomitance. It should also be performed in both right and left head tilt. To reduce variability during and in between measurements and to reduce redress, allow the patient to read the optotype slowly on the distance chart. Allow the patient to have few seconds of binocular viewing before switching the occluder. Should I continue? Dissociated vertical deviation is measured with the help of a base-down prism placed in front of a hyperdeviating eye. However, when it presents with a true vertical deviation, initially a base-up prism is placed in front of the hypodeviating eye and the upward refixation movement is neutralized. When there is no upward refixation movement noted, the prism undercover test is again repeated with the help of a base-down prism in front of the hyperdeviating eye. Over elevation in adduction could be either because of a dissociated vertical deviation or an inferior oblique overaction. When associated with inferior oblique overaction, the simplest clinical way to identify them is a hypotropia of the abducting eye on lateral gaze, a fundus torsion, and an associated V-pattern strabismus. When DVD is associated with superior oblique overaction, the hypertropia is more in abduction and down gaze, and there can be an associated A-pattern strabismus. Performing the standard prism undercover test reveals a greater magnitude of dissociated vertical deviation when compared to a routine prism and cover test. Identifying the committance, associated oblique muscle overaction, and asymmetry all play an important role in surgical decision making. Dissociated yes. Sure. Yeah.
Otherwise, it was good. It was quite an exhaustive presentation on DVD. You worked hard on that. Okay, thank you.
Thank you.
Shashikant Shetty is there. Okay. Actually, presenter is Sneha Pandurangan. Okay, please come. The video. Okay. Naik Milind. Okay, Neha. Presenting author Neha Ghosh, please come over to present your video titled "Sparing the Sea in MMCR."
Hello everyone, my name is Neha Ghosh and I will be taking you through a minimally invasive technique of Muller's muscle conjunctival resection. Muller's muscle conjunctival resection or MMCR is a surgical technique for mild upper eyelid ptosis correction. Muller's muscle is a sympathetically innervated smooth muscle present posterior to the levator of 10 to 12 millimeters length. The activity of the Muller's muscle can be assessed by the phenylephrine test, in which 2.5% phenylephrine drops are instilled in the eye and the eyelid position improves due to stimulation of the sympathetically innervated Muller's muscle. MMCR is known to provide good postoperative contour and cosmesis with faster healing than the anterior approach to ptosis correction. But the main drawback is the resection of normal conjunctiva, which can lead to damage to accessory lacrimal glands and conjunctival goblet cells. It is also contraindicated in cicatrizing conjunctival diseases, and it cannot address dermatochalesis through the same incision. A simple modification of this surgery by sparing the conjunctiva eliminates the conjunctiva related drawbacks, and this video demonstrates the steps of this modified surgery, which can easily be emulated by surgeons keen to attempt this procedure. Once the patient is taken to the operating room, prepped and draped, a protective shield is put under the eyelids on the cornea. The eyelid is then everted over a Damar retractor, exposing the posterior eyelid tissues. Local anesthesia is injected into the subconjunctival space. Then a supratarsal incision is created. In this case, it is done with the monopolar cautery, and the conjunctival dissection is carried out superior to the superior border of the tarsus. The conjunctival flap is then reflected to expose the underlying Muller's muscle. Markings are made on the Muller's muscle following the 4:1 rule. That is, 4 mm of resection is done for 1 mm of required elevation. Then the Muller's muscle is held by fixation forceps, or in this case, stay sutures are passed through the Muller's muscle to lift it to facilitate the placing of the clamp. A putamen ptosis clamp is placed in the position incorporating the Muller's. Then a 6-0 proline suture is internalized laterally along the base of the clamp through a bolster and run in a serpentine fashion. It is then externalized medially and then reinserted and re-internalized and run again in a serpentine fashion along the base of the ptosis clamp, exiting the skin close to the initial entry site, again through the same bolster. The medial and lateral sutures are then tied to each other. After that, tissue glue is placed over the anterior surface of the conjunctiva. Simultaneously, the Muller's muscle within the ptosis clamp is excised using a 15 number blade mounted on a Bart Parker handle. The conjunctiva is then draped over the posterior ptosis suture and the eyelid is placed back in its normal anatomic position. This is a young lady who underwent left-sided conjunctiva sparing Muller's muscle conjunctival resection with a good postoperative eyelid lift, comparable to the outcome of the phenylephrine test. The advantages of preserving the conjunctiva are substantial. These include conservation of anatomically normal tissue and reduction of suture-related complications like corneal abrasion, since the conjunctiva is draped over the sutures and covers them during postoperative healing. I hope this video demonstration inspires you to try this variation of the procedure too. Thank you.
That was a nice innovation or variation of the MCR procedure. Thanks, Neha. So, how was this video shot? Like, what was it with the handle?
Yeah,
camera
it was a handheld camera. So the phone was connected to a stand and it was shot that way. So
with the phone?
yeah,
Phone camera.
phone camera. Yeah.
Actually good. But I think because it was freezing and unfreezing.
I think so. What happened was in the middle we had to change devices, unfortunately.
Okay.
So the second device probably had
Otherwise,
some
surgery was
problems.
very good. I think it is done by Dr.
Milind.
Milind Naiksa. Very, very clean and very good surgery. It was very demon, but only thing that the video was a little, but good. Thank you so much.
Thank you.
So, okay. So going on to present the next presenter, Dr. Subhav Prashad. Okay, and he would be presenting your video on upper eyelid blepharoplasty. Okay.
Leonardo da Vinci, through his study of the human form, described symmetry as a key factor in beauty and noted that the ratio of thirds should be respected. The mask of beauty created by Marquardt was constructed from the triangles and pentagrams consisting of sides of golden ratio 1.618:1, sometimes called as the phi. Hallmark of a youthful face, termed as the triangle of youth, is represented by a base down triangle with the apex directed at the mentum. This heart-shaped face is seen in the age of 20s to 50s, but is ultimately replaced by the pyramid of aging when this triangle of youth flips. Blepharoplasty. The word blepharoplasty is derived from the Greek word blepharon, which means eyelid, and plesine, which means to form. It refers to the surgical excision of skin, orbicularis oculi, and fat. Differences exist in the anatomical features of the various ethnic groups. For example, among the Asiatic eyelids, there is presence of pretarsal descent of the preseptal pad of fat, fusion of the orbital septum with the levator aponeurosis below the tarsal plate, a shorter vertical dimension of the tarsal plate, and a lid crease that begins in the medial canthal area. Topographical variations exist between men and women. For example, an ideal female eyebrow has been described as resembling the wing of a gull. In women, the eyebrow lies 0.5 to 1 mm above the orbital rim and is arched with its apex between the lateral limbus and the lateral canthus. However, most men tend to have straighter eyebrows. Eyebrows serve as a foundation for the lids. The skin of the eyebrow is thick with a corresponding thick subcutaneous fibroadipose layer. The eyelids are complex specialized facial adaptations designed to protect, moisten, clean the ocular surface. The upper eyelid crease results from the superficial insertion of the levator fibers. The crease lies about 8 to 11 mm above the central lid margin. The distance between the skin crease and the upper eyelid margin is termed the tarsal platform. Ideally, the ratio of the tarsal platform to the distance between the upper lid crease and the brow should be the golden ratio or the phi. The upper lid has medial and a central fat pad. The medial fat pad lies medial to the levator aponeurosis and is separated by a weak septum from the central fat pad. The central fat pad sits on the levator aponeurosis encased in a thin membranous sac. The orbital lobe of the lacrimal gland lies laterally and being posterior to the septum can be mistaken for the preaponeurotic pad of fat, removal of which must be avoided. The indications for blepharoplasty include functional and cosmetic. Functional indications are dermatochalasis, which refers to a laxity or redundancy of the eyelid skin and muscle due to loss of elastic tissues, thinning of the epidermis, weakening of the connective tissue in the eyelids, and mechanical forces such as rubbing and aging. Blepharochalasis. Steatoblepharon is the prominence of eyelid fat pads and applies to the upper and the lower eyelids. It may be associated with the weakening of the orbital septum and the overlying orbicularis oculi muscle and the skin. Quintessential in the run-up for blepharoplasty is a comprehensive preoperative evaluation which involves assessment of the quality, quantity and relative symmetry of the redundant skin, assessment of the brow position, the presence of fat pad herniation and grading of the medial and the central preaponeurotic fat herniation, evaluation for a possible lacrimal gland prolapse, presence of any concrete ptosis, lack of thalamus, presence of an intact Bell's phenomena and assessment of the orbicularis strength, assessment of visual acuity, pupillary examination, ocular motility, intraocular pressure, examination of the anterior segment, and finally the fundus exam. The single most important aspect of blepharoplasty is the marking. If the lid creases are symmetric, they are considered as the base of the incision. The marking of the lower incision in blepharoplasty involves placement of the 4 dots as follows. Point A is placed at 5 to 7 mm above the medial commissure. Point B is placed 9 to 11 mm in the midpupillary plane. This also correlates with the superior edge of the tarsus and the lowest position of the eyelid fat below the orbital septum. Point C is placed laterally 8 to 10 mm above the lateral canthal angle, and point D is marked at 12 to 15 mm from the lateral commissure directed superolaterally towards the lateral orbital rim. One of the common techniques followed in blepharoplasty is the pinch technique. It involves the use of a pair of smooth forceps to grasp the excess skin above the lid crease incision just until the eyelashes begin to rotate upwards. This is marked as the maximum amount of skin that can be safely removed. For a clear margin of safety, after having established the tarsal platform show, superior border of the incision should pass no closer than 1 cm from the inferior border of the brow. The varied types of skin incision in upper eyelid blepharoplasty include classic crease incision associated with more chances of a temporal brow droop, scalpel shaped incision which negates the extra brow droop, and third is the Belin-Vias incision which goes beyond the temporal brow margin for counteracting the lateral hooding. Surgical technique in blepharoplasty involves making the skin incision with the tip of a monopolar radiofrequency probe. Skin flap is then raised from the underlying orbicularis oculi muscle to expose the muscle bed. Following this, fulguration of the retroorbicularis pad of fat is done. Orbicularis is closed with 6-0 vicryl interrupted sutures. The skin wound is then closed with 6-0 proline sutures in a horizontal mattress fashion. Here are a few examples of patients who have undergone upper eyelid blepharoplasty with good functional and cosmetic outcomes. In a nutshell, blepharoplasty is the most common facial aesthetic surgery. To attain an optimal result, care and attention must be given to patient selection, expectations, preoperative evaluation, surgical technique, and postoperative care.
Very nice. Very nice.
Very nice surgery and especially the cinematography.
Thank you, sir.
So, who was the editor?
We have a dedicated individual who works as a team member.
Okay,
So,
that's great.
Very nicely made video, like you covered all aspects of it starting from the history.
yes,
Well
thank
done.
you. Thank you.
Call upon the next presenter, Dr. Meghna Dikshit. She will be presenting her video on clinical evaluation and management of proptosis.
Proptosis.
is defined as forward protrusion of the eyeball. Protrusion of more than 21 mm or more than 2 mm asymmetry between the two eyes is considered abnormal, while exophthalmos is defined as the proptosis of eyes in association with the thyroid eye disease. The algorithm for the approach to a case of proptosis: after history taking, an ocular and systemic examination and specific examination of proptosis, the provisional diagnosis is made, and after imaging, the revision of provisional diagnosis if required, and after investigation, confirmation by histopathological examination, followed by the management plan. The history of present illness: when did it start? Was it trauma related? The progression: was it acute, subacute, or chronic? The pain: was it mild, moderate, and severe? The changes in vision: the diplopia: was it monocular versus binocular? Was it horizontal versus vertical? The skin changes associated with edema or erythema, past medical history of thyroid cancer, diabetes or HIV, or family history of cancer or thyroid. In ocular examination, we'll start with general examination, in which visual acuity decreased due to optic nerve compression or corneal exposure, and refraction acquired hyperopia due to mass indenting the posterior polar globe. IOP raised in thyroid orbitopathy due to restricted ocular motility, and in arteriovenous fistula due to elevated venous pressure. In eyelids, there could be lid retraction, lid lag in thyroid orbitopathy, or S-shaped lid thickening in neurofibromatosis. In anterior segment, in conjunctiva, there could be chemosis seen in severe inflammation, salmon color patch in lymphoma, and dilated episcleral vessels in carotid cavernous fistula. And in cornea, there could be exposure keratopathy due to lack of thalamus. In iris, there could be Lisch nodules seen in neurofibromatosis. And in pupil, there could be relative afferent pupillary defect. The ocular motility limitation seen in direct muscle involvement due to mechanical limitation, compression of nerves, or carotid cavernous sinus thrombosis. The optic nerve examination will start with color vision, followed by fundus examination, where there could be discolor, dysedema, optociliary shunt vessels, or choroidal folds. The 6 P's of orbital history and physical examination are pain, progression, proptosis, pulsation, palpation, and periocular changes. In pain, there could be inflammation of sensory nerve within the orbit, severe pain seen in orbital cellulitis, orbital abscess, vascular condition like lymphangiomas, high flow CCF, and metastatic lesion. Moderate pain seen in idiopathic orbital inflammatory disease, ruptured dermal cyst, and trauma, and dull boring pain seen in bone erosion due to neoplastic tumor. The progression could be acute within hours to weeks seen in traumatic orbital hematoma or infective orbital cellulitis. The subacute 1 to 4 weeks seen in inflammatory orbital inflammatory disease and thyroid orbitopathy, and in neoplastic condition. The chronic more than 1 month seen in neoplastic, benign or malignant or inflammatory diseases. The axial proptosis due to lesion of intracoronal space arising from optic nerve or central space due to optic nerve glioma, optic nerve sheath meningioma, cavernous hemangioma, schwannoma, neurofibroma, or orbital varix. The downward displacement of lobe seen in fibrous dysplasia, frontal mucocele, subperiosteal hematoma, lymphoma, neuroblastoma, neurofibroma, or thyroid orbitopathy. The upward displacement of lobe seen in lacrimal sac tumor, lymphoma, or maxillary sinus tumor. The lateral displacement of lobe seen in lacrimal sac tumors, ethmoid mucocele, midline granuloma, or nasopharyngeal tumors. The medial displacement of lobe seen in lacrimal gland tumors and sphenoid ring meningioma.
In pulsation, the vascular tumors, particularly those with an arterial component, will pulsate and have an associated drury when applying the bell of the stethoscope to the globe, seen in arteriovenous fistula, high flow carotid cavernous fistula, and aneurysm. The palpation, the mass is evaluated for the extent, border, size, consistency, tenderness, skin over the lesion. Large lesions with tendency to extend across the midline are mostly malignant. Resistant to retrodisplacement of the globe may indicate a tumor or thyroid orbitopathy. There, in periocular changes, there could be edema present. The evaluation of proptosis, the nausea sign, the protrusion of the eyeball beyond the orbital rim when examined from above and behind the patient, the worm's eye view looking up at the patient from below while the patient tilts his head back, the loose exophthalmometer from the lateral orbital rim, the cornea diameter, the distance is measured. In Hartel's exophthalmometer, the reflection of the cornea is measured in the mirror that is given. The measuring of proptosis on a CT scan is done through Hilal and Troppel method. The measurement of dystopia in case of non-axial proptosis is done with the help of two scales. In investigation, we'll go ahead with the hematological CBC, ESR, VTRS, thyroid function test, serum ANA, C-ANCA, ACE levels, BUN and creatinine levels, chest X-ray, Mantoux test, and Cassoni test. Case of hydrated cyst. In X-ray, calcification, hyperostosis in case of meningiomas, water view in case of blowout fractures. The CT scan provides detailed images of bony structure and adjacent soft tissue and is particularly useful in case of thyroid eye disease or orbital tumor. The MRI allows for the better soft tissue differentiation in periorbital, orbital, and intracranial spaces. The arteriography and venography are useful imaging techniques, particularly in case of aneurysmal lesion, arteriovenous malformation, and carotid cavernous sinus fistula. The orbital ultrasonography useful in diagnosis and characterization of vascular lesion, other intra and extracorneal masses, and extracorneal muscle involvement. The management general measures are lubricants and dipping of the eyelids, and specific measures are according to the etiology. Proptosis is defined as forward protrusion of the eyeball. Protrusion of more than 21 mm or more than 2 mm asymmetry between the two eyes is considered abnormal, while
Thank you, Meghna. We next call Chaitanya. Yeah, so Chaitanya will be presenting on surgical synergy when your assistant is just a rather very intelligent system.
So I'm a new practitioner. Like I started in last 1 year, and so basically the ours is a very old OT setup, and we are completely use the advent of artificial intelligence and Amazon Alexa devices to automate or make it more friendly for the surgeon, so that he does not need to depend on multiple staff or people. So this is a small presentation. I kept the video with voiceover as well. Hi, my name is Dr. Chaitanya Aravindankam. Today I am here to talk on the topic of surgical synergy, where you have an OT assistant for being a smart AI assistant. The main problem with today's individual practitioners is your OT assistant might not be skilled, or you do not have enough OT assistants at the right moment. So I have programmed my entire OT with voice commands, as it will be much easier for surgeons to do with voice commands. So let me show you how the first voice command is designed into the OT. So let us see how everything comes to life with this one simple command.
Alexa, start theater.
So with just one voice command, you can switch on the lights, your microscope, your retro illumination, your TV and video recorder above that. Here I am simulating the surgical scenario, and here is the view through our 4K surgical camera. So here I am simulating a surgery, and to cut the glare from behind, so I use this command.
Alexa, turn off backlight.
This turns off the light that is causing any glare for me. So when you come to doing Rexis, I want to have retro illumination. So I will use this command.
Alexa, turn on retro illumination.
Now I want to record my video or live stream my video directly to YouTube. So I'll use this voice command.
Alexa, start recording. Alexa, stop recording.
Suppose you want some help from outside the OT, or you need to call a person, you can use this customizable commands.
Alexa, turn on bell.
While you are doing the surgery, if you want to control your phaco machine parameters, or your foot pedal switches fails over time, you can always customize with voice commands.
Alexa, next mode. Alexa, next mode. Alexa, previous mode. Alexa, next mode. So suppose you want to change some certain parameters in the factor machine while you're operating, you can do it with just a voice command. So you can say like, Alexa, increase bottle height. Alexa, decrease bottle height. You can even say like, Alexa, decrease power. You can say like, Alexa, decrease vacuum. Alexa, increase vacuum. Alexa, decrease aspiration. Alexa, increase aspiration. Alexa, change grade. Alexa, change grade. So that's how you can operate your machine.
So now once your OT is done, you can completely turn off all the equipments and devices in the theater with just simple customizable commands like this.
Alexa, stop theater.
interesting. So how, I was curious to understand that how did you pair the Alexa with your LG TV with the Infinity
So the entire setup costs you like
with the
six to
bell?
everything costs you like 6 to 7 thousand. Everything is available on Amazon. Only thing is we need to figure out exactly what things need to be kept together, and the commands what I have given are just the bare minimum, like the basic commands what I have kept in the FICO machine. Like you can and do it like endless possibilities. You can actually program it to decrease the vacuum to 200 or increase the power to 70. You can be very specific, and then it still works to that specific point.
Machines also allows that modification in
It's nothing to do with Alcon company basically, because we are not actually fiddling with any of the machine's proprietary software or any of the hardware. So we do it completely out of the machine only.
How
So
do you link it with the FACO machine?
so
What do you
yeah,
use?
yeah.
So the somebody comes and help you with this with the
No,
Alexa?
I've
You
done it
do
my
on
own.
your
Like it took me like a month to figure out the things,
Okay,
but
it's something more
it's like
technical,
try
I
and
think.
fail.
Okay. And the
So
other thing is you can direct the machine. I mean, you can reduce the vacuum by 40.
yeah, everything
and
can be done.
That can be done.
Everything, like it's depends on each surgeon. Suppose I am a surgeon who requires like my optimal surgery parameters would be this thing, and I want, if I something facing a difficulty like a softer or a harder cataract, probably I'll go 20 or 30 down and 20 or 30 up. So that is my personal preference. If the other surgeon wants 50 or 60 down and up also, it can be
Alexa
customizable.
listens to every surgeon.
Yeah, as per the surgeon
That's
basically.
great. Okay.
So
Nice.
these are the major 4 devices that we use. No, see, I'm just showing you the PPT. So here are the 4 things that we require, and then this is the machine which we use, and this machine do have a remote. So any machine that has a remote can be done this thing. Any FACO machine. So I think nowadays like all the FACO machines come with a remote, so it shouldn't be a problem for it. So this is a very beautiful video recorder. It costs you like 10,000, but this completely is hands-free. It's a very small device. You can connect your hard disk to it. At 1 TB SSD you can connect, and you can directly record your surgery. At the same time, you can live stream it to anyone, anywhere in the world. So, yeah.
It was the third talk. I'm sorry, I was in the myopia session. I informed earlier also. 38. Yeah, this is a compilation of innovations that we made in the pediatric ophthalm across Aravind Eye hospitals. Small, still very crude innovations, but the idea was to make pediatric ophthalm more easier.
This is a video compilation of innovations from our institute that have made pediatric eye examination less cumbersome for the doctor and more fun for the child. The authors have no financial interest to disclose. Torchlight examination. Children often have a low threshold for torchlight examination. The direct torchlight causes photophobia and irritation, which makes the child to look away. Also, plain torchlight becomes dull and boring for them. Our aim as an examiner is to make the examination child-friendly without taking much time. So, we came up with an innovative idea which is extremely simple and can be carried out for each and every child. Here are a few self-explanatory steps using easily available items with almost no cost to make a torch with pictures to make it interesting to the child. We made these colorful pictures and placed them in front of the torch and showed it to the children, simultaneously doing a ocular examination. The translucent paper reduces the photophobia without compromising the quality of examination. In addition, colorful images help the child to focus on the torch for a longer time. The advantages are quick anterior segment examination, examination of fixing and following patterns, Hirschberg's test, cover-uncover test. This proved to be simple yet very useful, child-friendly, economical tool in our day-to-day practice. Slit lamp examination. Getting the child to fix a target for slit lamp examination can be a difficult task and can be a cause to miss important examination findings. These colorful, cheap, very useful fridge magnets can be a solution to this problem. They can help in making a child fix. These are so value for money and durable. It's less than 20 rupees for each slit lamp. AIO examination. Indirect ophthalmoscopy can be a nightmare to the child and to the examiner. Rigid watches with child-friendly themes easily available in the market, which will help make our lives easy in doing an indirect ophthalmoscopy in a child. Just change with a click of a button and can help in keeping the child preoccupied. Characters and themes which the children love will grab the child's attention and help us get a view of those all important discs, backgrounds and maculas. Prism holder. It can be cumbersome to place prisms in front of the eye away from you, and it is never possible to hold prisms in front of both eyes without the help of an assistant. On occasion, we even had patients hold the prism. Here is an innovative 3D printed prism holder which made in-house, which can be easily attached and detached to the patient's glasses. After detaching from the frame, prisms can be placed in position effortlessly. It is stable and comfortable both for the examiner and the patient. IPD adjustment can be done easily just by moving the prisms away. It works on almost all spectacle frames. Squint evaluation. Doing a squint evaluation in all the gaze positions is a Herculean task for the doctor, as the patient inadvertently changes head position. This can give wrong measurements and mess up our surgical plan. We often have inter-observer variations in measurements. Hence, we created a head holding device which is adjustable, gives great support with built-in occluder holder and near target holder. It also has a protractor with a small weight attached to a thread to measure the angle of neck flexion and extension, to measure the deviations accurately in and down gaze. Doing 9 gaze measurements has never been this easy, quick and accurate. These simple innovations can make a world of difference to our day-to-day examinations and indirectly to a child's life. Thank you. This is a video
It's quite innovative and be helpful to rest of us to imply in our practices. Thank you.
So are these available for sale? Like you have an innovation center or something at Arvind?
The magnet ones are just off Amazon. The torchlight is a do-it-yourself. We're trying to make it into a product, and the prism holder, both the prism holder and the squint, both are still very crude devices. We're actually working with IIT students now, and they're helping, trying to make it a better product. It still is difficult to do in lateral gazes and all that, measure in the lateral gaze, and the IPD still doesn't work very well, but we still use it as a handy device. We are still using it in our clinic and in some of the other centers also. It's not commercially, not yet.
Good, thank you.
Thank you.
That we finish our session. So one person is absent. Soumya, Dr. Soumya B. Thank you everyone for a patient listening.